name's Kate Schlatter. I'm one of the GPOs for the CCBHC program team. And I just want to say thank you to Selby for setting up this meeting and helping us today with the logistics. So today we're going to be going over the updated criteria backed by popular demand is David Devorney. He has done a few of these webinars, but today it's just for our grantees. And hopefully we'll have some time at the end to go over questions. So if you have questions throughout the webinar, please make sure to put them in the chat and I'll be collecting them for the end. Okay. David, I'm going to turn it over to you.
Great. Thank you so much, Kate. It's great to have everybody here and I appreciate your interest in the program, all the work you're doing on your grants. And I have done this presentation in a couple different venues at the National Council meeting over the summer in Los Angeles, and we did it for states. And so this is a repeat. I apologize, but hopefully still worthwhile. But I'm just going to be running through the criteria today, and then hopefully have some time for questions. And so, to be honest, it is really a verbal summary of the 65-page document. So I'll try and keep it lively, but it is just basically me walking through the basics of the criteria. Today, I'm going to be talking about the updated criteria. I'm not going to be talking about the previously existing criteria that were released in 2015. So just so you know, that's kind of my assumption is we'll be talking about the updated criteria. I'm happy to answer questions on the existing criteria at the end, but we are really trying to move to shift to focus on the updated criteria at this point. And so we'll run through the 6 program requirements. We'll talk a little bit about what the changes that were made from the 2015 criteria to this updated version. And then we're going to talk a little bit about expectations for attestations. And then we're going to move into questions and answers at the end. Yeah, this is also kind of this is for grantees, so it's a little bit less of a kind of a public event. So I'm hoping we can keep it pretty informal today. And again, we're happy to answer questions for you at the end. And then work with your project officer, or if you have further questions after the webinar, you can always email ccbhc@samhsa.hhs.gov. Thanks. All right, and so I think this is review for a lot of you. And I just want to make sure, Kate, you're seeing our slides, right? They're still showing, is that right? Okay, good. All right, was displaying a little funny on my screen, so I just want to make sure, but okay, good. So this may be review for some of you, but I just wanted to run through the timeline for the development of the CCBHC initiative, because I think it's helpful to understand the current context for the criteria. So CCBHCs were initially authorized through the Protecting Access to Medicare Act of 2014. And that act authorized the federal government to create certification criteria for CCBHCs based around requirements that were included in that statute. It authorized the creation of a prospective payment system for a Medicaid demonstration and really created the concept of the CCBHC, that legislation. It also provided funding for a round of planning grants, which was awarded in 2016. And we awarded, in 2015, we awarded 24 state planning grants that went through 2016. And out of those 24 state planning grants, we selected 8 states to participate in the demonstration, and you can see those listed here. In 2017, those 8 states joined the demonstration, and then shortly after the demonstration was created, the next year in 2018, Congress gave us money to create the CCBHC Expansion Grant Program, which supports the CCBHC model, as you all know, through grants instead of through the Medicaid demonstration. 2 additional states were added to the demonstration in 2020 and 2021 as a result of the CARES Act. And it's important to note that all this time we had released the criteria back in 2015, and so it had been a number of years, even at 2021, 2022, since we created the criteria. And in that time, we as a federal government have been collecting a lot of feedback about the criteria. We've been hearing from states, from communities, from providers, from CCBHCs, from others about the criteria, and we always kind of had it in the back of our minds that we would be updating the criteria at some point. And then in 2022, the Bipartisan Safer Communities Act authorized the addition of 10 additional states to the CCBHC demonstration program every 2 years starting in 2024. And we realized that there were going to be a bunch of new states that joining the demonstration as a result of this act, and we thought, if there's going to be new states joining the demonstration, we've been thinking about updating the criteria. we really need to update the criteria before those states join, because the last thing we want to do is have them join under the old criteria and then change the criteria, very early in the development of their state programs. And so this really put us under pressure to update the criteria, and that's part of the reason why we engaged in the updates to the criteria. But I want to talk a little bit more about the VSCA legislation. Did a couple of important things. I think the big thing, and this is good news for a lot of you expansion grants out there, is we're going to be adding 10 states to the demonstration every 2 years. This is the authority we were given through the Bipartisan Safer Communities Act. Until we run out of states, there's no cap on that. So we should be adding, 10 states until there's no more states that want to join the demonstration every 2 years. That also provides us with funding for planning grants. We have about $30 million from that act for planning grants. We're using $15 million this year, which are for grants that are in operation right now. We awarded 15 planning grants back in March, and we are going to be awarding another 15 planning grants in 2025. So we're going to be supporting these first 15 are going to be competing to join the demonstration in 2024, and then the ones from 2025 will be competing to join the demonstration in 2026. And so, the good news is that means we should be in more than 30 states, by the, so in a majority of states by 2026. As far as the CCBHC demonstration goes. So I want to talk a little bit about the updated criteria first, and then talk about some of the changes, after that. So I'm going to just jump right into the criteria. I'm going to try and do it quickly and do a little bit of energy because it is a little dry, but I think it's important. And I always say this: if you want to understand the CCBHC model, the first thing you should go to is the criteria, because if you really want to understand what these clinics have to do, it is the criteria that you should go to first. And if you're working on the CCBHC program and you haven't, and I think you probably heard us say this on webinars before, we're going to have the links in just a second, a couple more slides. Go find the criteria and read them. They're 65 pages. I think that it'll help you in understanding the full requirements of the CCBHC model. So these are the requirements that kind of frame the criteria, and these are set in statute. So these were not changed in the updates to the criteria. So there's 6 broad program requirements that are the sections that this criteria are built around. The first is staffing. The second is availability and accessibility of services. The third is care coordination. The fourth is scope of services. And the scope of services really lays out the 9 required services that are also included in the statute. You can see those on the right side of the slide here. So there's 9 required services for the CCBHC model: crisis services, outpatient mental health and substance use services, screening, diagnosis, and risk assessment, person and family-centered treatment planning, psychiatric rehabilitation services, community-based mental health care for veterans, outpatient primary care screening and monitoring, peer family support and counselor services, and then targeted case management. There's a section of the program requirements on quality and other reporting, and a section on organizational authority and governance. Usually when I do this slide, I give you a brief snippet of what each of these things is. I'm not going to do that because I'm about to go through them in incredible detail in the next set of slides. So, and as I said, we're going to be focusing on the updated criteria today. And I should note that these criteria, they really set a floor. So this is the minimum basic expectations for CCBHCs. Individual clinics or states may choose to have more stringent requirements, or they may go beyond the criteria in terms of what they provide in terms of the service package. But this is the minimum expectations that all CCBHCs should meet. That's what's laid out in the criteria. And as you're looking at the criteria document, and again, I would really suggest you do that if you haven't. Even if you have, it's good to refresh your memory. Just to note that there's little green dots throughout, and those specify areas where there is explicit state discretion in how the criteria may be implemented. And that's within the demonstration program, the CCBHC demonstration program. It's a little bit less applicable for CCBHC expansion grantees, especially for those grantees that aren't in a demonstration state. So, and I should note, for those places where there's discretion in a state that's not a demonstration state, or for CCBHCs that aren't participating in a demonstration program or another state CCBHC program, really then it's up to that individual CCBHC and how they take advantage of those flexibilities outlined in those green dots. So the first program requirement is staffing. And so and there's a reason that this is first. So the first thing and the first program requirement is the community needs assessment. And the community needs assessment is really important to the model. It really is supposed to set the stage for how the programs are built out, for patterns of staffing, for the scope of services, for types of trainings that are offered, for the geographic distribution of services, where you have service locations. This is really a very fundamental piece of the initiative. The idea is that it is flexible, but part of that flexibility is designed to respond to whatever the needs of the community being served are. And the way we find out what those needs are is through this needs assessment. So there's a reason it comes first. The needs assessment is required before certification and then every 3 years thereafter. And so this is something, if you are coming up on the 3 years since your last needs assessment, you really need to be thinking about how are you going to redo that needs assessment. And as I said, it informs a lot of different areas of the program activities, and these are some of the explicit areas that are called out in the criteria that the needs assessment should inform. Those include staffing plan, languages used, chosen services, how you do outreach and engagement in the community, what partnerships you have, your hours of service delivery. These are all kinds of things that should be informed by the needs assessment. There's also some general staffing requirements across all CCBHCs that are included in this first section 1A. So the CCBHC should be developing a staffing plan that enables the clinic, the CCBHC, to provide the 9 required CCBHC services. There's also requirements for staffing for having a medical director and staff on board who can prescribe medications for opioid use disorder. There's requirements to have addiction medicine staffing, so specialists in addiction medicine. And if you don't have that staffing, then you should have consultation in place to have around issues related to addiction medicine. There's requirements to have staff in the base CCBHC. And again, this is important because this is not for DCOs. It's separate from the DCO. The CCBHC itself has to have this ability to prescribe medications for opioid use disorder, that capacity around addiction medicine, either directly or through consultation. They have to have licensed substance use disorder treatment providers at the base CCBHC. They also have to be able to have staff who can care for children and youth with serious emotional disturbances and adults with serious mental illness. Those are requirements across all CCBHCs, regardless of whether they have DCOs providing services in those areas. Providers at CCBHCs have to meet the regulations to provide the required services in their states. They have to be licensed and credentialed to provide behavioral health care, in those areas that are outlined as requirements for staffing. All right, I think I went too fast. So CCBHCs also have to meet standards around cultural competence and other training. So they have to have training plans at the CCBHC. And so some of the required areas for training are cultural competency, evidence-based practices, person-centered and family-centered treatment, trauma-informed care, care for co-occurring mental health and substance use disorders, and then training in military culture. The trainings that are in place are supposed to align with standards called the class standards that advance health equity and improve quality of services and eliminate disparities. And there's detail about that in the criteria. CCBHCs are supposed to provide services in a linguistically competent way, so they have to ensure access to services in the languages that are used in the communities they serve, and providing interpretation and translation services where necessary. Documents and other, that the CCBHCs are providing need to be accessible to people receiving services, including being provided in the languages that are spoken by the populations being served. And again, that choice of languages, it needs to be informed by that needs assessment. There's requirements around the availability and accessibility of services. This is a key part of the CCBHC model, and we've moved into the second program requirement area here. So there's general requirements around access. So the CCBHC should be a safe, clean, and welcoming environment. And so, I was in a CCBHC in Southern Michigan, and they just had a great, you walked in, there was a little Keurig coffee machine, I think, in the corner. There was a play space for children in the waiting room. It was clean. There was art up. There were comfortable chairs. And it was the kind of place where you would walk in and it would inspire confidence that you were coming into a professional organization, you were going to receive good services, and most of all, it made you feel welcome. And that's exactly what we want to see for CCBHCs, and so it's an expectation inside the criteria that it be a safe, clean, welcoming environment. And I think, it's tough because I know a lot of our safety net services, a lot of providers it is hard to find money for physical infrastructure, but this is something we should really be striving for as part of the criteria in the CCBHC to create that clean and welcoming environment. So there's requirements around locations, hours of operation, addressing transportation needs and use of telehealth and telemedicine. Again, needs assessment should inform how CCBHCs are using those options for increasing access to services. And CCBHCs also importantly have to have plans in place and policies in place to ensure continuity of operations in cases of natural disaster or other interruptions of services. There's requirements in the CCBHC model, and these are really important requirements around the timely access to services and assessment. So there's a preliminary triage at the first contact with the CCBHC. So when the CCBHC is picking up the phone for that first call or getting that first referral, they should really be determining if that person's in crisis. If that person is in crisis at that point, it's determined that they're in crisis, they need to get a mobile crisis response if that's what's needed within 3 hours. If they need to come to the building and can get in the building, that's great, but they should be able to provide a mobile crisis response if possible. If there's an urgent need that doesn't rise to the level of crisis, the CCBHC needs to be able to see them within 1 business day. For all other appointments, and this includes requesting an appointment for an existing CCBHC client, they need to be seen within 10 business days for routine care. There has to be a person and family centered treatment plan developed within 60 days, and that has to be updated no less frequently than every 6 months. And again, this is part of the access requirement. So the way this works is, the expectation is the CCBHC is getting the person into care quickly. They're having this initial treatment, the assessment completed, having our comprehensive evaluation completed. They're developing this treatment plan within 60 days. This treatment plan should be able to draw on the 9 required CCBHC services, and it should include all the services that would help that person out of those 9 required services. And so the idea is, once this treatment plan is up and running, this person's getting the full complement of CCBHC services, and that's an important part of the access requirements. It also means that the CCBHC has responsibility to have those services in place, either directly or through a designated collaborating organization. Crisis services are a big part of the CCBHC model, and so there's a section here about access to crisis services. And as I said, crisis services have to be operated 24 hours a day, 7 days a week. The CCBHC needs to work with its local emergency departments to assist people in crisis who present to the ED. They need to work with their local law enforcement to improve the safety of individuals in the crisis and in the community, to coordinate and try, when possible, to get people into the mental health care system where they can be served safely. There is, of course, the provision that CCBHCs have to provide services to people regardless of their ability to pay or place of residence. And so a CCBHC can't turn down somebody because they can't pay. CCBHCs can charge for services on a sliding discount schedule or a fee schedule, but there is a requirement they need to serve everybody regardless of their ability to pay, including individuals who are underinsured. There is a requirement that CCBHCs cannot deny services to people because of place of residence, because they don't have an address. CCBHCs have to serve folks if they're experiencing homelessness, if they don't have a place address, if they're from another county, if they're from another state. CCBHCs need to serve them. CCBHCs don't have to provide ongoing services to someone who's outside of their service area, but they should provide that immediate response, provide crisis response if necessary, and then connect back to that person's place of residence to try and get them connected with care if needed. One of the things that we added, actually, I'll go back to that really quickly, is that we have added in the latest version of the criteria, the requirement CCBHCs, or an option for CCBHCs, that if there is a population that's transient, that's moving in and out of the service area, and I can think of a number of kinds of populations to apply to, so people involved in the criminal justice system that might be leaving the area for short jail stays or prison stays or other reasons, individuals experiencing homelessness who are transient, who are moving in and out of the service area, children in the child welfare system who might be putting in out-of-home placements that are outside of the service area but coming back to the service area. The CCBHC can still continue to work with those folks in a continuous way if the CCBHC elects to. So I think that's something that's really important. We want to provide continuity of services for those really vulnerable populations. So we're in the third area now, care coordination. Care coordination, we often say, is the linchpin of the CCBHC model. I think sometimes people often focus on the required services, but I almost think care coordination is just out there as important as those required services. CCBHCs need to have a range of policies and procedures in place around care coordination. So they need to be working across a spectrum of health and human services. So they need to be working with physical health, behavioral health, social services, child welfare, employment, criminal justice. They have to be engaged in active care coordination. Oftentimes, the people being served by CCBHCs are people who need a lot of support, may have complex lives, may have not full capacity to always do this kind of coordination and planning on their own. And so the CCBHC really needs to step into that gap to ensure that they're getting a full complement of services within the health system, and then also that services are coordinated with other systems outside of the health system. CCBHCs have to develop a crisis plan for individuals who come in. For some people, that could be as simple as, if you're having suicidal thoughts, call 988. But for other folks, who experience crises, it could be, include development of psychiatric advance directives, developing detailed plans, identifying triggers that may lead to crisis, developing a plan to help people avoid crises, making sure that they know who to contact on the treatment team to when there's a potential crisis emerging, those kinds of things. CCBHCs have to have capacity around health information systems that support the care coordination function. And so they have to have an electronic health record that meets ONC standards and can support quality measurement and reporting and other provisions in the criteria. CCBHCs have to have agreements with a range of entities around care coordination. And so some of these entities include FQHCs, inpatient psychiatric providers, opioid treatment programs, withdrawal management providers, residential treatments for substance use disorder, schools, Veterans Affairs, Indian Health Services, inpatient acute care hospitals should be on this list, other human services. And so we've kind of changed the rules about these agreements a little bit. And I'll talk about that when I get to the changes to the criteria in a second. But we have made this a little bit easier because I know this has been something that's been tough for CCBHCs under the 2015 criteria, the existing criteria. There's requirements that CCBHCs be providing services in a team-based interdisciplinary manner. And so the CCBHC should have, a range of professionals that meet the needs of the people they're serving. And that the person receiving the service should be at the center of that team, but that team is really responsible for coordinating across medical, psychiatric, psychosocial, emotional, therapeutic recovery supports. I want to talk a little bit about the designated collaborating organization role before I get into the 9 required services. So the designated collaborating organization role, or DCO role, I think you're all aware of, is a role that's identified in statute. So CCBHCs can elect to either provide directly the services that are required under the CCBHC model, the 9 required services, or they can choose to provide those services or parts of those services through DCOs. DCOs are not organizations or providers that are not under the direct supervision of the CCBHC. They're not part of the CCBHC organization, but they are engaged in a formal relationship. That means a relationship, a signed agreement with that CCBHC to deliver one or more elements of the required services. That's really important that from the perspective of the person receiving services or their family members, services provided through a DCO should feel like a part of a coordinated package, seamless package. So for the person, it should almost not be as if they're going to a separate organization. They really need to see this as one whole package of coordinated services. And I've heard this, it's not contracting out services, it's really about contracting in services into this comprehensive array. This should include a coordinated intake process, coordinated treatment planning, information across the CCBHC and the DCO to make sure that people aren't repeating information when they go to that designated collaborating organization. There should be direct and facilitated communication between the CCBHC and the DCO to prevent the person receiving services for their family from having to do that care coordination. Regardless of DCO relationships, and this is really important, CCBHCs are responsible for assuring that people receiving services get all 9 services in a way that meets the requirements of the CCBHC criteria. And so it's not okay for a CCBHC to say, well, our DCO relationship fell through, we can't provide those services. The CCBHC is still on the hook for providing those services. And so the CCBHC should always be watching these agreements very closely to make sure that they're meeting the certification criteria, because if your CCO agreement falls through and you don't have a backup plan, then you're out of compliance with the criteria. It's important to note also the CCBHC is maintaining responsibility for care coordination within that DCO relationship. So the CCBHC needs to make sure this is a seamless service package for the person receiving the services, regardless of their DCO relationships. I'm also going to talk a little bit about a 51% rule when I get to the updates to the criteria, which is something I know we've had a lot of questions about. I'll talk about now. So the CCBHC is again responsible for access to all 9 required services. So the CCBHC, regardless of their DCO relationships, has to provide at least 51% of all service encounters across those 9 services, those 9 required services. So they have to provide a majority of the services directly by the CCBHC. They can't have the DCO provide more than a majority of the services, as measured by the number of encounters. So the CCBHC has to provide the majority of the services as measured by encounters across those 9 required services. And again, any of the 9 required services now can be delivered through DCOs. That wasn't something that was the case when the program was first established, but that's where we are now. CCBHCs have to provide services across the 9 services in a person-centered and a family-centered manner. And that means they need to involve the person receiving services and pay attention to their needs, preferences, and values while they're developing treatment plans and providing services. And of course, involving their family as appropriate in that process also. CCBHCs need to provide services that are responsive to the race, ethnicity, sexual orientation, and gender identity of the person receiving services. Now getting into the 9 required services. So for C, it's easy to remember because C stands for crisis. It covers crisis behavioral services. So crisis services, again, can be delivered directly by the CCBHC or through a DCO agreement with an existing state-sanctioned crisis system. CCBHCs have to provide 3 kind of core functions as part of their crisis services, the required services. The first is emergency crisis interventions. And this basically means they need to participate in their local system for crisis response in terms of air traffic control. And so what that means is they need to be a part of the local system that tracks a person in crisis to make sure they get what they need, and need to be coordinated with that local system. CCBHCs, again, have to either directly or through a DCO provide 24-hour mobile crisis response. And so if someone's in crisis, the expectation is they get a mobile crisis response in 3 hours within the CCBHC service area. CCBHCs, and this is a new addition with this new updated criteria, they have to have some capability around crisis walk-in capacity. So during their operating hours, they need to have a space where someone in crisis can come and be at the CCBHC. This is on a voluntary basis. We're not expecting CCBHCs to set up complete crisis stabilization centers or to have inpatient units, but they should have a place where someone in crisis can come and be safe and help work through that crisis at the CCBHC building during operating hours. And an important part we've tried to add an emphasis around in the updated criteria is that CCBHCs really do need to be responding to suicide risk. From the beginning of the crisis through the duration of services provided, they also need to be responding to overdose risk in the same way. So when there's an overdose risk, either from that initial crisis contact, but all the way through service provision, they really need to be thinking about suicide and overdose prevention. And we did add this, and this is just for the crisis services. This doesn't apply to any of the other DCO provisions, but CCBHCs can request approval from SAMHSA to use a state-sanctioned crisis provider that doesn't quite meet the requirements outlined in the certification criteria. SAMHSA is going to review these requests on a case-by-case basis. And the reason we did this is, as you know, we're very excited to just hit the 1-year anniversary of the 988 Suicide in Crisis Lifeline. And states across the country and communities across the country are working to develop crisis systems. And if there is a state-sanctioned crisis system that's out there in the CCBHC's area, that almost meets the CCBHC criteria, but not quite. We'd be willing to consider whether we'd waive some of the requirements so that the CCBHC can work with that crisis provider. What we don't want to do is, if there is a basically solid crisis system in a community, we don't want to force CCBHCs to build a separate crisis system if there's one in that community that works, pretty well for our purposes. And so, that's a provision we actually haven't anybody take us up on yet, but that is an option that's out there. The other thing is that states can request a blanket waiver on behalf of the CCBHCs in their state for their crisis systems. So that's another part of that provision. All right, program area 4, scope of services continued. So the next area is screening, assessment, and diagnosis. And so this lays out the requirements around screening, assessing, diagnosis. So it lays out that CCBHCs have to do an initial triage and an evaluation, and then they have to do a comprehensive evaluation. And there's the criteria list out the components that have to be required in each of those pieces. There's a requirement that CCBHCs use standardized screening tools to ensure quality of care. So you need to use kind of validated, commonly used assessments in the field and screening tools. CCBHCs, of course, have to provide treatment planning as one of the core services. So they need to involve the treatment team, the person required services that should be based on those the screening and initial screening and comprehensive evaluation. And they should be building out that treatment plan that draws on across the 9 services to provide what people need to support their mental health or address their substance use disorder needs. The next area is outpatient mental health and substance use services. And so this includes general behavioral health care, including psychopharmacological treatment. CCBHCs should be using evidence-based practices, again, drawing on that needs assessment to decide what meets their population needs. They should be providing developmentally appropriate care across the lifespan, including for children and families. And so it's important. CCBHCs have to serve everybody. Everybody includes children and families and children and young people. And that care has to be developmentally appropriate. So it's not okay to say, we've got some therapists that generally focus on adults, but they could probably serve children too. No, we really need to be providing developmentally appropriate services for children and youth. We added a requirement that CCBHC is providing substance use to care in alignment with ASAM levels 1 and 2.1, and that's up through intensive outpatient. So CCBHCs do need to have, with the criteria update, intensive outpatient substance use disorder treatment program. And CCBHCs have to address tobacco use disorder as a part of their substance use disorder programs. CCBHCs can refer out to services. That's allowed. They need to provide the 9 required services, but if there's specialized services that are in their community, they can certainly refer to those services if they think they would better serve the people that they're serving. So the 5th area is outpatient primary care screening and monitoring. The CCBHC has to first of all work with their medical director to define a set of conditions that the CCBHC is going to is going to screen for. These are physical health conditions and then monitor over time. And the CCBHC, there's also a few select conditions that are identified in the criteria that the CCBHC has to include in their list of conditions that they're screening and monitoring for. These are physical health conditions. And they need to monitor these conditions over time. They need to provide the care coordination to connect back and make sure that people's physical health needs are being met. The CCBHC isn't directly providing the primary care services. They aren't directly providing the physical health care services, but they are screening for and then monitoring these conditions to make sure that they're being addressed. And they have to coordinate with primary care as a part of this. As part of the CCBHC criteria is ensuring that people have a primary care provider and working with that primary care provider. And there's a lot more detail in the criteria about how this is handled, including how you use labs and other things as a part of monitoring. The 6th area is targeted case management. This is intensive support to assist people in receiving services and sustaining recovery and gaining access to needed medical, social, legal, educational, housing, vocational, other services and supports. And so this is really stepping in to provide care for people who need a lot of care coordination. Specifically, it should focus on individuals who are experiencing high-level risk, including times of high levels of risk. And this could include things like transitions from a hospital, reentry into the community from a jail or prison, and periods of homelessness when people are at high risk for a number of poor outcomes and risks. The next area is psychiatric rehabilitation services, this includes evidence-based. The CCBHC should be providing evidence-based rehabilitation services for both mental health and substance use disorders. And this is important. This is a new addition. It needs to include, these package services need to include supported employment services, and they also need to include services that support social inclusion, as well as supports to find and maintain housing. The next area of the required service is peer supports, peer counseling, and family and caregiver supports. And so peer supports and family supports are a core part of the CCBHC model and part of an expectation of what's delivered through the CCBHC model. And there's a lot of flexibility that CCBHCs have and what they might include in this. They can offer peer-run crisis respites, warm lines, peer-led crisis planning, peer navigators, peer support for older adults, peer education and leadership development, peer recovery services. There's a wide flexibility in what they can provide under this criteria. Of course, that you do have to have that peer and family support capacity as a part of the CCBHC system. CCBHCs have to provide community-based care for veterans, and that care needs to be provided consistent with the clinical guidelines contained in the Uniform Mental Health Services Handbook of the Veterans Health Administration. And there's detail of what is entailed in that outlined in the certification criteria, but you can also go to that handbook to see what's included in it. And sorry, I realize there's a lot of questions popping up as we're going. I'm going to try not to dip in, but I did see the question about the PAC services. I'm just going to answer that. No, ACT or the served community treatment model isn't required part of the psychiatric rehabilitation services. ACT could definitely be a part of the CCBHC care continuum, and it could fit in, I think, under psychiatric rehabilitation services, targeted case management, outpatient services. It kind of crosses a number of the areas, but ACT is definitely something that is we like to see it as a part of the CCBHC model. But I didn't say specifically that ACT is a part of the CCBHC model. All right. The fifth, and we're out of the required services now, we're now into the next area, the next program requirement. So CCBHCs have to participate in a lot of activities around quality and other reporting. So they have to collect, report, and track quality data on required standards, including clinic and state collected measures. We haven't to date required CCBHC expansion grants that aren't participating in the Medicaid demonstration to collect these measures. There's a set of clinical collector measures. We are going to be doing that moving forward. And so that is something that's going to be coming your way for expansion grantees, is to report on the clinic collected measures. And we'll have a little bit more information about those later in the presentation. CCBHCs also have to engage in continuous quality improvement planning. So they need to focus on continuous quality improvement. They have to have a plan to do that. And their continuous quality improvement plans need to include an explicit focus on suicides, overdose, all-cause mortality, hospitalization for mental health or substance use disorder, and then also disparities. And that disparities piece is a new addition under these criteria. So that's something we really are focused on, is trying to figure out how to address health disparities through the CCBHC model. There's requirements around organizational authority, governance, and accreditation. So CCBHCs have to be a nonprofit organization or part of government, or operated under the authority of the IHS or an urban Indian organization, sorry. CCBHCs, their governance needs to be informed by representatives of people being served by CCBHCs, or people with lived experience or their family members. And at least 51% of the governing board of CCBHCs has to be comprised of individuals with lived experience of mental or substance use disorder or family members, or there is another approved method for participation of those groups in board governance involving folks with lived experience. And so the criteria go in a little bit more detail of what that option looks like. So the simple way is just to have 51% of the board comprised of people from these groups, but there is another option for developing an alternate pathway to see people with lived experience and family members, and those being served by the CCBHC represented in the governance of the CCBHC, which includes developing another pathway to bring that into the board. And there's requirements for what that might look like, what that has to look like in the certification criteria. if you don't elect to have 51% of the organization, the CCBHC organization's board, meet the requirements here. CCBHCs should be enrolled must be enrolled as a Medicaid provider and licensed, credentialed, or certified to provide mental health and substance use disorder services and appropriate services for children, youth, and their families, unless there's some kind of strange state provision that prevents it. But generally, that's the expectation. They be a Medicaid provider of these services. They also have to be certified by their state or having had an attestation accepted by SAMHSA to be a CCBHC. All right, so that was, in a very small nutshell, the CCBHC criteria. I hope you know that this was a very kind of general overview. The criteria themselves are 65 pages. I should also note there's a lot of really important information in the appendices to the criteria. And I know it's very tempting once you're 40 some pages into a 60-page document to say, well, I read the criteria. I won't worry about the appendices, but especially in the terms and definitions, there's a really important detail around the needs assessment, around the designated collaborating organization relationship. And so unfortunately, you are going to have to pay attention to those terms and definitions in the appendices in addition to the information included up front in the sections that I went through in the certification criteria just now. So yeah, again, I'll refer you back to that document. All right, so now I'm going to talk about the criteria update and some of the detail there. So as I said in the beginning, we've been considering updates to the criteria for quite some time, and the passage of the Bipartisan Safer Communities Act made that really urgent. So that's why we jumped in and did this now. We have years of experience with the CCBHC model. We really like the CCBHC model, and we attempted to build on the CCBHC model and make it stronger through the criteria updates, but we really felt like it's a very basically sound model to start with. So I think that put us in a good position to make improvements, but understanding we really feel like we had a very strong model to build off of. We undertook the criteria updates to respond to developments in the field. So there's newer terminology used in the field. The 988 and crisis system work was vastly different in 2015 when the criteria were originally released. We wanted to account for that. There's a lot of emerging best practice in the field that we've been able to capture, I hope, in the criteria. We also tried to add some flexibilities to address workforce shortages. And we also tried to address areas of the criteria that were no longer current. The 2015 criteria referred to Office of National Coordinator standards for electronic health records that didn't exist anymore. We also tried to address areas that were suggested by CCBHC states and other stakeholders that needed to be addressed, such as focusing on substance use disorders and addressing social determinants of health. So we went through a pretty intensive process to update the criteria. To start off, in November of last year, we solicited public input and partner input. We had calls with over 15 stakeholder groups, including federal partners and other stakeholders. We had listening sessions. We had a kickoff webinar. We had a general session, a 4-hour listening session for the general public. We also accepted a round of written feedback on the existing criteria to start with to inform how we looked at the criteria updates. We took all that information we received in November, and we worked pretty steadily, and in December released a draft updates to the criteria for public input. Those were up for 30 days. In January, we had webinars to the field on the criteria updates. We had also webinars for states. And January 20 was our deadline for feedback on those updated criteria. We received pretty extensive comments from the field, so thank you. I know a number of our grantees provided really strong comments, and we really appreciate that. So we received comments from over 130 organizations and individuals. I'm not going to go through this all in detail here, but you can see we got comments from a number of states, a number of stakeholders, a lot of CCBHCs, so thank you again for your input. And then other organizations like consulting groups are the evaluator that we use for the Medicaid demonstration provided us with some comments. There were other groups that also provided comments. And then we also got a really good feedback from just individual interested practitioners who just wrote in in an individual capacity. So we're really happy to get all of that feedback. We posted the updated criteria on March 16th, incorporating that public feedback. We made updates in a number of areas. There were 3 specific areas of focus that kind of emerged for us as we were looking at the updates. One is we did try and make changes related to crisis care. Second is we did try and improve a stronger focus on substance use disorder to respond to the overdose epidemic. And then we also took some steps to try and address health equity concerns. We also made changes in a number of other kind of general areas. So we tried to make some changes to the criteria in terms of places where it's unclear. We tried to increase flexibility and reduce burden where we could. We tried to make the model stronger in some areas where we felt like it could be strengthened. We updated our language and some of the examples, and then we tried to clarify language wherever possible. We also updated the quality measures, which I'll talk about in a second. So these are some of the specific areas that we updated the criteria. In crisis care, and this is in those top 3 areas, we required coordination with the 988 crisis centers serving the CCBHC service area. That's one piece. We updated the crisis service areas, the crisis service requirements, as I said, to add walk-in capacity, and then also that requirement that you coordinate with the local air traffic control system. We also tried to align the crisis requirements in CCBHCs with other requirements that exist through or other description of crisis services through SAMHSA's national guidelines, and also the CMS mobile crisis program. We made improvements, we hope, to address the overdose epidemic, including that requirement for either addiction medicine staffing or consultation. We included a stronger emphasis on the ability to prescribe buprenorphine and other medications for opioid use disorder, including coordination with opioid treatment programs. We added revisions around addressing overdose risk. We added the requirement that CCBHCs have an intensive outpatient program for substance use disorders. We added requirements around the quality improvement process to address fatal and non-fatal overdoses. We required consultation with prescription drug monitoring programs, and we added a focus on harm reduction as well. We also had a focus, as I said, on health equity. So we updated our training requirements to focus on the national, cultural, and linguistically appropriate services standards, the class standards. We included a stronger focus on outreach to underserved populations. And then we required that quality improvement plans have an explicit focus on health disparities. Other areas of revision to the criteria from the 2015 version to the updated version. We updated our guidance on electronic health records to align with the current ONC requirements, or Office of National Coordinator requirements. Right? We changed the requirements related to designated collaborating organizations. As I said, DCOs can now provide any of the 9 required services, but there is that 51% requirement that CCBHCs have to provide at least 51% of the required service encounters directly. We required that CCBHCs be enrolled as Medicaid providers in this updated version of the criteria, and we adapted the criteria so that they could apply to SAMHSA expansion grants. When the original criteria were written, there weren't any expansion grants, and so we tried to write the criteria this time that they could apply specifically to SAMHSA expansion grants separate from the Medicaid demonstration. We tried to add flexibility where we could, so we added flexibility. Previously, the medical director was required to be a psychiatrist unless it was in a health professional shortage area, in which case the CCBHC could look for another medical director who's a prescriber. If there's not if they couldn't find a psychiatrist, we expanded that so it could be anywhere in the country, recognizing the shortage of psychiatrists that exist out there. We relaxed the requirement around primary care involvement in treatment planning. We reduced there used to be required treatment plan updates quarterly. We reduced that to be required twice a year. We relaxed requirements for care coordination agreements. And so previously, CCBHCs had to have signed agreements with a range of community partners. We backed off of that a little bit, and we for those care coordination requirements, CCBHCs should try and get signed agreements as their first line of attempt when when working with their care coordination partners, especially the required partners. They can't get those required agreements. They can develop joint protocols. So maybe that other organization's lawyer says, hey, we're not going to sign anything, but we're happy to work with you to develop joint protocols. If you can't get joint protocols, then the CCBHC should develop its own care coordination protocols on what it does to coordinate with those other organizations, even if those other organizations won't play ball. So that's a change that provides some flexibility. We also provided flexibility for clinicians. They do have to address all the required areas of the for the assessment outlined in 4D4. but they can use their clinical judgment on how much depth they want to go into. So they don't have to use a full screener or full assessment for every section of it if they're talking through with somebody to say, okay, well, maybe we don't need to go into as much detail here because just in chatting with you, I can tell that, there's not much to go into. So that's designed to reduce provider burden there, and also burden on the persons being served. We added language also to allow CCBHCs to use recent evaluations from trusted providers. So if there's a good provider down the street and they said, hey, look, you'd be better served at that CCBHC, but they'd already conducted that initial assessment, and you trust that provider, you can use that information as initially without having to redo things. There's also a process for CCBHCs, as I said, to request use of a state-sanctioned service provider that doesn't quite meet the CCBHC criteria. That's an option that I mentioned earlier that is new in this version of the criteria. We made a number of additions to strengthen the model. So we tried to provide clear guidance or more comprehensive guidance on the community needs assessment. Again, that's in the appendix. Please read the appendices. We added a stronger focus on shared decision-making and client preferences throughout. We added requirements around assisting clients to access benefits and enroll in programs. We added detail around outpatient services requirements. We added detail around primary care screening and monitoring. We again have required that CCBHCs be providing as a part of the psychiatric rehabilitation, supported employment, and then also support around housing and social inclusion. We recommend the use of measurement-based care in the CCBHCs. We tried to add an additional focus on serious mental illness, serious emotional disturbances, and then severe substance use disorders throughout the criteria, recognizing that CCBHCs need to serve everybody, including those individuals with the highest levels of need. We added a requirement around training for co-occurring mental health and substance use disorders, something that I think is really important. We added language encouraging same day and open access scheduling. We added language clarifying that treatment of tobacco use disorders is part of outpatient services. We added language clarifying and encouraging that services be provided out in community settings. We do want CCBHCs to be providing services out in communities, either home-based services, mobile services, or services in other community locations like schools, emergency departments, shelters, coordinating with jails, those kinds of things. We updated our language throughout. So the old CCBHC criteria referred to individuals as consumers. We've changed that to the person or people receiving services. We stopped using the word detoxification and are using the correct medical termination of withdrawal management. We have started using the term medication for opioid use disorder, alcohol use disorder, or tobacco use disorder instead of medication-assisted treatment. We've also updated our language around peers. We made several clarifications around what should be included in the comprehensive screening and assessment. We clarified the definition of targeted case management. We clarified requirements related to representation of people with lived experience and family members in governance. And we removed there's a lot of random explanatory language around HIPAA in the old criteria. We've taken that language out because there's lots of HIPAA guidance available through the Office of Civil Rights at HHS, and that's where that is maintained. And we also made some minor changes just throughout to try and clarify language where possible. And so what's the timeline for coming into compliance with the criteria? So the big date is July 1st, 2024. And so states that are joining the demonstration as a result of this latest round of planning grants, and they're going to be joining under the new criteria. All CCBHC expansion grants will be expected to meet the updated certification criteria for July 1st, 2024. And so that means this is something that should definitely be on your radar. Existing state demonstration programs are expected to come into compliance with the criteria at the start of their demonstration year beginning on or after July 1st, 2024. So different states in the demonstration have different demonstration year cycles, and some of them are after July 1st, 2024. So they'll have a little bit of time to come into compliance with criteria after that point. If there's a clinic that is both expansion grantee and in their state demonstration program, they still need to follow the guidance for expansion grantees and come into compliance with the criteria sooner. And there's other state initiatives that support CCBHCs. Those are encouraged to come into compliance around the same time frame of July 1st, 2024. Should also note that CCBHCs are allowed to come into compliance with the new criteria before those dates. And so CCBHCs won't be penalized or be found out of compliance if they move into compliance with the criteria earlier than these dates, even if they do so in a piecemeal fashion. We anticipate there's a lot of changes that CCBHCs are going to have to make in order to meet the new criteria. We know that's not going to happen overnight or all at once. And so it is okay for CCBHCs to be working on this over time in a piecemeal fashion with the goal of meeting the new criteria by these deadlines. I do want to talk about the quality measures a little bit. And so we have made some updates to the quality measures. I'm not going to read through all the quality measures, but we are proposing, or we're going to shift to a system of 5 clinic collected measures and 13 state collected measures. You really need to be paying attention to these clinic collected measures because those are what you will be reporting on. We've tried to strengthen the focus on time to service, crisis services, and social determinants of health, as well as medications for opioid use disorder in the updated measures. And we're going to be using updated technical specifications because the original technical specifications that were released for the existing measures, they're now out of date. And so this is an important opportunity for us to update those technical specifications. We're hoping to have those out later this year. We're going to be also removing and making optional some of the previous measures because we wanted to make sure that we aren't increasing burden in the number of measures with this update to the measures. And you can see the measures here, the ones with little asterisks next to them are the ones that have been are newer, have been significantly expanded. The other measures that don't have that are pretty much the measures that existed before. All right, and here's links. I promised you links. Here they are. There's links to the updated criteria, links to the original criteria, summary of the changes, and there's also a red line so you can see exactly where the changes were made that's posted on our website. And so I'm going to go into the Q&As right now, and I know we have about a half an hour, and we have some questions that Kate was nice enough to solicit ahead of time, and we'll try and go through those first, and then I'm hoping to get through the Q&As in the chat. I'm going to try and go through these pretty quickly to save as much time as possible for the questions that you might have. So I'm going to try and race through these questions and answers. So first question, do grantees need, or I should say, we're also working on a written version of these FAQs. We're just going through clearance right now and in kind of the development stage. We're hoping to get it out soon. I know that's going to be much more helpful to you than just saying it on the webinar, but we want to give you a flavor of what we're thinking right now to respond to some of your questions. So first question, do grantees need to have criteria fully implemented at the time of attestation, or to be permissible for the attestation to describe implementation plans that are not fully actualized yet? So the attestation deadlines, and this is probably most relevant for the PDI grants, it's really our expectation that you be in compliance with the criteria 1 year into your grant. And that's the reason we're asking for your attestation at that point. The criteria are huge and they're complex, and I'm not going to say that everybody is always 100% in compliance, but our expectation is that you be in compliance, and we want to work with you to get you in compliance. If there's something that's not quite in place at the time of your attestation, please be honest in your attestations, work with us, we'll work with you. But our expectation is that you be in compliance at the end of that first year when that attestation is submitted, but we will work with you around meeting the criteria because we want CCBHCs to meet the criteria. What supporting documentation should be submitted with the attestation? I know we're working on getting you some guidance right now on what should be submitted with the attestation, and I think we are also planning a whole separate webinar on the attestation process. Kate, correct me if I'm wrong, and so we should be getting you a lot more information about that. But I can say what we've done to date. We generally ask that CCBHCs, kind of outline how they're meeting the criteria, that they test that they're meeting the criteria at a sub-criteria level, that they provide some general description of how they're meeting the criteria, and they provide some supporting documentation or reference to supporting documentation that would substantiate that they're meeting the criteria. We typically ask that these submissions be less than 30 pages, and they typically are close to that. You don't have a required format, but we often will send out examples of what we think are high quality or strong attestations for you to look at. We don't have one required format for the attestations. But again, we'll go into that in more detail in the attestation webinar. Let's see. Criteria 1C2 initially uses the wording individual furnishing services. However, the criteria later state each employee who has direct contact with people receiving services. We're interpreting the wording of the second to mean the first wording. Is that correct? No. Individual furnishing services means someone who's directly providing services. So like a therapist or a case manager, or a care coordinator, someone who's really directly providing services to somebody. And for them, they need to meet specific training requirements. But there's a requirement that all in-service trainings be captured for every staff person who has contact with CCBHC, with people being served by CCBHCs. And so the people in that latter group, it's actually a slightly broader group. I'll refer you back to the detail of that, but that they aren't the same thing. The first group is a little bit more narrow group. The second group is a little broader group. Are smoking cessation services required? So CCBHCs are required to screen for tobacco use and tobacco use disorder. They are also required to provide treatment for tobacco use disorder. They're also they have to have capacity to provide medications for the treatment of tobacco use disorder, sorry, not to provide the medications, but to prescribe those medications. And so, taken together, I think that sounds a lot like, to me, like smoking cessation programs. We don't use that term smoking cessation services, but certainly treatment of tobacco use disorder is a part of the required outpatient services. So fifth question, what clients self-report meet the primary care screening requirements in 4G1 and 4G2? 4G1 and 4G2 are very, and actually 4G3 is pretty relevant here too, are pretty detailed. The medical director has to outline a set of physical healthcare conditions building on an existing list of conditions that are required within the criteria. And they have to develop protocols for initial screening and then ongoing monitoring of those conditions. I think there probably are cases where, person doesn't have a lot going on and they could probably say, yeah, I saw my primary care provider, everything's fine. And maybe that would suffice in that case. But generally, you can't just rely on self-report for all these requirements. So you really need to look at the detail of these requirements in 4G1 through 4G3 and fulfill those requirements, which includes, again, initial screening and then ongoing monitoring for a set of conditions. And that goes a little bit beyond just self-report. Is there a standard lab requisition that CCBHCs can use when ordering labs for clients? No, because the requirements are going to differ across CCBHCs depending on what that CCBHC and their chief medical officer decides to include in their protocols. So there's not one standard set of requisitions. That's something that each individual CCBHC would develop and probably would differ across clients too. Number 7, when we extend our hours in the night and weekend, do we need to ensure that all CCBHC services are provided during those hours? We would like to limit the available services to those that are most sought after, such as counseling assessments. No, you don't have to offer every single service during extended hours, but you should really look at that needs assessment again to decide, A, when you're going to have those extended hours. Are you serving a lot of working families and they need to be able to get to services after 5 o'clock? Are you serving a lot of people who just can't get anywhere during the week, so you need to have some service, some weekend hours? You need to be taking those kinds of considerations into account when you're thinking about your extended hours. And then you want to have the services available at the time when they're needed for those individuals. And so, thinking about what aspects of the non-required services you have available. The non-required services, you have to provide all of them. You should be making them accessible to your population, but the exact hours you're providing them, you don't have to provide them for all the time you're available. It's okay to have, less staffing during extended hours based on the needs of the people being served. So several times through the new current criteria, standard references made back to the needs assessment, for example, informed by the needs assessment, please advise how to meet those standards for which there's nothing in the needs assessment that addresses one of those specific areas. So we do have kind of updated standards in the terms and conditions section of the criteria that defines what's in the needs assessment. And so you should be looking at that to define what you need to collect as a part of a needs assessment. Needs assessment should be looking at the population health needs of the people you're serving. And so I think you can, even if there's not a specific answer, look at the general trends. What are the services that people need? What are the disorders they're facing? What are the other systems they're involved with? What are their demographics? What languages do they speak? Do they come from certain cultural backgrounds? All these things, even if they're just generally examined within the needs assessment, probably can inform your delivery and design of services and how you're providing services, even if those specific services aren't addressed within your needs assessment. And so I would just try and take the general to inform the specific. but also, try adhere to the requirements for the needs assessment that are included in the criteria in the terms and conditions section. All right, number 9. We're almost there, so hopefully a little less will be talking and some questions from other people soon. What does the CCBHC require if an individual seeking services as a veteran who is dishonorably discharged? They still need to provide those services to that person, regardless of whether they were dishonorably discharged, is the short answer to that question. They still need, those are the ones outlined in that section of the criteria. I think it's 4K, but they'd have to go back and double check that. Number 10, do grantees need to serve children, or can they use DCOs to fulfill this requirement? So important, yes, CCBHCs have to serve children and families in a developmentally appropriate manner. CCBHCs can use DCOs to serve children and families, just as they can use DCOs to serve anybody else. But CCBHCs have to have a core staffing capacity, some internal capacity to serve children and families, and especially children with serious emotional disturbances. So CCBHC has to have at least some capacity in that area. They can't farm out all their child and family services. They have to have some staff with that background and training. Let's see, criteria 3B4 and 3B5 speak to CCBHCs working with DCOs. The CCBHC is not working with the DCO to provide any of the required services. How to respond to those 2 criteria when preparing the attestation? Do we simply say that we are not currently partnering with the DCO? Yes, the easy one. You don't have to worry about it. If you're not using DCOs, that probably simplifies your life. You don't have to worry about going through that detail if you're not using DCOs. All right. Number 12, 1B2 states staffing shall be appropriate to address the needs of people receiving services at the CCBHC as reflected in their treatment plans and as required to meet program requirements for these criteria. Question, all things including in a treatment plan are not necessarily provided by the CCBHC. Was this an error, and should this have stayed reflected in the staffing plan? No, the CCBHC should be looking at the treatment plans, again, looking at, what's being provided across all the 9 required services and then the care coordination to support those services. What's in those treatment plans, and then designing their staffing to provide that entire package of services, responding to what's being provided in the treatment plans. We recognize that treatment plans may include, services that are provided by organizations that are outside of the CCBHC. So organizations you're referring to, and that's fine. CCBHC still has to provide the care coordination to connect with those services and support people across that relationship. And so it doesn't, just because not everything in the treatment plan is provided directly by the CCBHC doesn't mean that those treatment plans shouldn't inform the staffing. That is the language we meant to include here. All right. 13, per standard 4C1, what is the expectation of CCBHCs regarding the standard? If there's no call center that cannot coordinate with local crisis care, do we as a CCBHC need to take steps to implement one as a part of the grant? We have been looking at the cloud-based platform that could do this with law enforcement and 988. Okay, so there is not a call center that meets the 988 standards in every CCBHC community, but every CCBHC community could be receiving referrals from a 988 call center that serves their area. So CCBHC still need to coordinate with 988 call centers, even if that 988 call center is outside of their service area, because even if they are half the state over, they could theoretically be routing calls, people in crisis, to the CCBHC. The CCBHC could decide that they need to set up their own crisis call center to meet this capacity. That's another way that CCBHCs do it, but they don't have to. They could work with the existing 988 call center that serves their area. That would be one of the ones that's closest to them. If you go to the Vibrant Emotional Health website, there is a link to be able to find all the 988 call centers, and you should probably be looking at the ones that are closest to you. You may know them already because you may already be getting referrals from them. But that's the piece there. And then obviously anything that CCBHCs want to do within the criteria that improves their coordination with law enforcement and 988 is great. So if you want to take that on to develop and look at developing a cloud-based platform that's going to have people have better coordinated responses in crisis, that's great. That sounds like something we'd love to see you do. It's not necessarily required, but it does seem like it would be a good thing to do to help people in your area. All right. Yeah, and I'll try and find that website. I should have had that ahead of time. I'll see if I can drop that into the chat with that in a second. All right. let's see. Standard 4C1 states that crises have to provide, CCBHCs have, this is under crisis receiving and stabilization, states that CCBHCs have to provide the service and a minimum include urgent care, walk-in mental health and substance use disorder services for voluntary individuals. Further along, the standard states that services provided must be capable of addressing crisis related to substance use, including support following a non-fatal overdose after the person is medically stable. Per the standard, this support needs to be available as a walk-in service to voluntary people. Does this standard extend to requiring the CCBHC to go to an emergency room or provide support there after an overdose? I think this is important to do, but it would mean developing a specialized crisis response team module for non-fatal overdoses. So there's several parts of the criteria that respond to this. In fact, CCBHC should have protocols in place for responding to people for all emergency department and hospitalization episodes, not just those related to overdose. And so CCBHCs should have a response and I think there's language in the criteria that talk about having protocols in place for a response within 24 hours for someone who's been in the hospital or emergency department. The criteria, you kind of have to go as far as the criteria say. I think what you're describing here goes a little bit beyond the criteria because there's probably flexibility beyond a specific mobile crisis model that would respond in these cases. I would refer you back to the criteria, and there's several places that call out what you need to do in terms of overdose response and prevention. And really, if you kind of do a word search for overdose throughout, you can kind of pull the pieces together and see what you need to do. I think this goes a little bit beyond the bare minimum that's required, but this is something that you would consider whether you need a specialized team for this or whether there's some way to use existing mobile crisis capacity or other mechanisms or people on call or there's a million ways to bake a cake. So there's a lot of different ways you could do this, but I think there's not an explicit requirement that you have a specialized crisis team to respond to overdose as a part of the CCBHC model. Although we do want people to be responding to overdose risk and to follow after overdose in a timely way to make sure you're connecting people to services and then addressing that ongoing overdose risk. Of course, people are very high risk for overdose immediately following one overdose. Right. Let's see. Is that it? Oh, I think that.
So I've been collecting questions in the chat, and there are a lot, and we're definitely not going to get through all of them today. But if we don't get to them, we will try to get answers that will be included in the written guidance.
And I just want to thank Anna because she posted the link that I was going to try and find in my draft answers. She posted it right there. So that's the link. Thank you, Anna, for posting that where you can find the map of Lifeline crisis centers.
Okay, so I tried to group these by topic, so I'm sorry if you put yours in absolutely first and it's not going to be first in order, but the first one that did come in was about demonstration states. So when will applications for the 2024 demonstration be open?
So the planning grants are underway right now. I think March 20th is our anticipated date for applications to be due to join the demonstration, and then we should be making announcements before July 1st, 2024 for those states that are successful in their applications to join the Medicaid demonstration.
Okay, there's a lot of questions about DCOs. You answered this for children, but there were specifically questions about substance use services. Can they use a DCO to fulfill all substance use services, or is it like children's where they have to have some core capacity?
They have to have licensed counselors on their staff. They also have to have people who can prescribe medications for opioid use disorder and tobacco use disorder. So that the CCBHC needs to maintain an internal capacity to treat substance use disorder, but they can certainly DCO out substance use disorder treatment services as well.
Okay, thank you. Yeah, there was a lot of questions about the level 2.1 substance use services, and I guess they were wondering like the level of care, if they could if they're not able to provide that level, can they refer out, or I'm sorry, use a DCO for that level?
You could use a DCO for the intensive outpatient program, and given the nature of the program and kind of the sensitive place where people are often in their recovery in those programs, you want to see a pretty heavy level of care coordination around a DCO relationship with an IOP, but that's something you could DCO out. But it's a pretty important part of the care continuum for substance use disorders. So it's something you can do internally. That's great also.
Do you consider psychiatric care medication management to be a routine service or a specialty service?
I'm not sure what the distinction is in terms of this, but psychopharmacological, services are a required part of the outpatient services. So it is something CCBHCs have to do.
Is the comprehensive assessment due within 10 days or preliminary services pre-assessment?
No. So basically, you need the comprehensive assessment to form the treatment plan that is due in 60 days. But not in 10 days.
In regard to the sliding scale, if we're serving people with no money, no means of payment, like homeless, or they aren't eligible for government benefits due to migration status, do we still need to administer a sliding scale, or can we just use the grant funds to cover the costs to provide the services? Our concern is that they may shy away from services should we give them a scale.
You can certainly use grant. That's an allowable use of grant funds. Whether that's in your budget is another question, but you should be able to work with your GPO to see if you need a budget amendment to figure out to provide care for people who can't afford care or people who are underinsured. That's something that's an allowable expense to the grant, and your GPO should work with you.
Can you clarify the responsibility of the CCBHC to provide services to clients with private insurance if the CCBHC does not have panel providers?
So I think underinsurance is a tricky one. If someone has insurance and they just want to come to you because you're a provider but you're not in there, I think that's something where you might say, like, look, you need to be on our sliding scale, and they might be at the upper end of that sliding scale. If someone has, there is insurance, private insurance that's pretty skimpy, even with parity requirements. And so if there's someone who has insurance, but it's just not going to meet their behavioral health needs, I think we want those people to be getting care. And so, that's where I think underinsurance is a little bit of a complex answer. I'm sorry not to give you like a clean yes, no answer, but I think it probably is that depends question a little bit. So.
Is there additional guidance for the development of the CQI plan?
So I refer you to the requirements that are on the criteria. We really try not to go beyond the criteria. We put a lot of there was a lot of long conversations about the wording, and we were in some cases wanted to leave flexibility up to the CCBHC, or in many cases actually leave flexibility in the CCBHC and how they define these. But the detail in that area, section 5, is what you should be looking to. And I should also note, if there are areas of the criteria you're like, I want to understand how people are doing this, like, talk to us and talk to the TA center. We should be able to do webinars, provide other supports, provide technical assistance about how other CCBHCs are approaching these things. So that's great. So people want to hear more about continuous quality improvement and how CCBHCs are approaching it. That's something we should be able to provide you with.
Does the CQI plan and measures need to cover all CCBHC clients or just the sampling population?
The whole CCBHC population. So the quality improvements about improving services for everybody. It's not really related to the sampling.
Is the CQI plan supposed to be based on statewide data and stats, or primarily for your specific CCBHC client data?
It could be a combination. If you have community or state data that's relevant to your population, that's great. I imagine most of the relevant data would probably be data that you have in house. But if there's community data that's helpful, that's fine. I think actually one area where community data would be helpful is if you're trying to understand how to address health disparities, looking at your community demographics. Kind of if you can get to a granular level, zip code, census tract level, and understanding the demographics of the area you're serving. I think that can be very helpful in identifying how you're going to address health disparities. But yeah, I think mostly it's going to be your internal data that's helpful, but there may be cases where there's community or state data that's helpful as well.
Can you provide more detail about the required crisis plan for clients?
Sorry, the required which crisis?
Crisis plan?
Oh, required. Oh yeah. So again, I think I talked a little bit about this during the when we were talking through the criteria, and really what's required is the language of the criteria. So if I say something that goes beyond that now, I'm really trying to do it for explanatory purposes, but you should go back to that language to see what's required. But the crisis plan should really be modulated based on the needs of the individual. And so for some people, if there's someone who's coming in, they're not showing up as a big suicide risk, they're getting pretty routine services, the crisis plan could be as simple as saying, well, I just want to make sure that, if you start having, suicidal thoughts, you should come talk to us, but you should also, have, that you can reach the 988 number if there's a local number. Of course, we're trying to promote 988, but, making sure they have that information in case they're in crisis and they need to call. That could be the crisis plan. But for other individuals, you may want to have a more in-depth crisis plan in place. If maybe there's people who have specific triggers, maybe there's people who need to monitor specific symptoms, maybe there's people who need to step up their level of support before a crisis. Maybe there's people who have substance use disorder concerns, and they need to develop a plan around recovery that kind of prevents them from having a substance use disorder related crisis. It really is about working with that individual and trying to figure out a plan that is going to help them, kind of hopefully prevent and avoid crises. And then also maybe have some plans in place for how they want to access services in the case that they're in a crisis. So, I really would rather go to this emergency department. I would, this is a list of my providers. This is how I'd like to have care coordinated services. This is the place I absolutely do not want to go. Do not send me there. Those are the kinds of things that might be in the crisis plan. People may also develop a psychiatric advance directive or a PAD that could be incorporated into their crisis plan, which kind of lays out the kinds of measures that they would like to see taken if they have a kind of a psychiatric episode. But it's been very on the individual.
That was another question, David, that came up. Are they required to create advanced directives for all clients?
No, it's not required for all clients.
Does a response via telehealth within 3 hours meet the mobile crisis response criteria?
No, I mean, there are cases where a telehealth response might be sufficient, but you really need to have either directly or through DCO the ability to provide that 3-hour mobile crisis response in person. If someone is actively suicidal, there needs to be someone who can get to them and make sure they're safe.
The crisis services are provided by a state entity. What documentation is needed by the CCBHC?
Sorry, if crisis services are provided by the state? Is that...
Right. So yeah, do they need to provide? Okay.
So it's not just a question of saying, hey, those services are provided by the state. We don't have to worry about that. CCBHC would need to enter into a designated DCO relationship with that crisis service provider that's serving their area. And so that means the CCBHC is working with them. There'd be payment provisions for CCBHCs in the demonstration that would go along with that. CCBHC should be providing care coordination. They should be following up after that mobile crisis response to make sure someone's connected with continuous services. They may even have people that would come out, and if the crisis service provider is providing that 3-hour response, but then they would connect with them soon after to ensure a warm handoff. There's a lot of things that a CCBHC should do around that crisis response, even if they're using the DCO relationship. And so it really comes back to that formal agreement, which would be a signed agreement between the CCBHC and the crisis services provider. So just the key takeaway here is that you can't just say, oh, there's a state system and they've got this. The CCBHC needs to be in really close collaborating in that relationship with the CCBHC. Need to meet all the pieces of that DCO relationship, so it should appear like a seamless interface for the person receiving services when they come into contact with that DCO crisis services provider.
How do grantees go about requesting or obtaining the waiver from SAMHSA for the state sanctioned provider that isn't providing 100% but close to it of the services?
So you can email your project officer. You could also email ccbhc@samhsa.hhs.gov. But I think for you have a project officer. The project officer should know to come back to us, to take a look at those questions.
Regarding primary
And
care,
I should just say also, I'm going to touch on that, and I've said this on a couple of other webinars. So we really want robust crisis services, and so we really are looking at things that are pretty close to the what's outlined. And so the example I've used in the past is if this is a very rural area of a state, and they just cannot on weekdays between 2 a.m. and 5 or 7 a.m. staff a mobile crisis team, but they do have staff who are on call during that time who can go out if needed. Those are the kinds of things we might consider in a waiver, as opposed to, you know what, we just call the police and the police take care of it. That's like we really want strong crisis services. So just to give you an idea of I just want to ensure that we're not giving waivers out for very broad departures from the crisis service requirements.
David, we're at time. We have about 10 more questions. Do you want to take another couple more, or?
I could probably do maybe, let's see. Why don't we just do 2 more questions and then call it a day, and then hopefully we can follow up on the others afterwards.
Okay. I'm gonna go to the questions about attestation then. So lots of grantees are asking when their attestation is due. For grantees who are already certified or have attestations, when do they have to submit, and what do they have to submit for the updated criteria? And we are going to go over this we're going to have another webinar where we'll go over this in detail. So I don't know if you want to touch on this really today, but we'll have a webinar. We're trying to schedule it for the first week of August, first or second week. So there should be another invitation coming out where we'll go into more depth.
That's right. Yeah, I think we're going to try and we're going to get you more detail about that in that webinar. So, and we're going to put out written guidance too. So,
okay.
So I don't have a lot more to add there right now.
Okay. Regarding primary care screening and monitoring of certain conditions, what suffices as screening? For example, we are looking to track asthma. Is it enough to just ask if the client has ever been diagnosed with asthma, or does screening need to go beyond that into symptoms?
That's a good question, and I'm not a doctor, so but I believe I'm trying to think of how screening would work in a primary care setting for asthma. That might be a question to come back to us with, but I think that in that case it may be sufficient. The other thing is to work with the primary care provider to see if there is a history. But I think that probably is sufficient for asthma. But I'm not a doctor, so that's actually a great question for your chief medical officer.
Okay, I'm going to do 2 more short ones here. Do psychiatrists still need to sign treatment plans?
I don't remember a specific requirement around that in their criteria. If there is some reference to that, if you can send an email and we'll try and get you a more complete question. So.
Okay. What was the other one? Can the medical director be a family nurse practitioner? We touched on this a little bit. I
think we have allowed that in some cases for a nurse practitioner to be the medical director. But it is, the CCBHC should try and find a psychiatrist first. So.
Okay. All right, I think that's it for today. We'll do our best to get these added to the FAQ that's being looked at.
Oh, and let's see, they also are asking for the email for questions. So yep. CCBHC at samhsa.hhs.gov. All right. Thank you, everybody. And sorry, I kind of just a lot of me talking today. Not the most exciting webinar, but I appreciate you you all sticking with it. And just talk to your project officer, email our mailbox if you have other questions. And I appreciate all the work you're doing. It's really important. So thanks, everybody.
Thank you.